All right, guys, let's talk about the respiratory system. Okay, in class, we talked about a case study. We have a 6-year-old female spayed domestic short hair cat. Yes, I know this is long hair, so we could just probably change that. But sometimes owners don't know. Moving on. Presenting for dyspnea, difficulty breathing, lethargy, not eating, so inappetence or anorexia, and open mouth breathing. It's not normal for a cat to open mouth breathe. There's no previous issues of anything. However, the owners did adopt about a year ago. So we don't really know. Okay, so like I talked about in class, this case, the doctor came over and put the ultrasound probe in the thoracic cavity. This here is our heart. We then can see that this surrounding darker pigmentation on the ultrasound is actually fluid accumulation. This fluid accumulation, unlike pericardial effusion, is actually going to be pleural effusion. And pleural effusion is buildup in the chest cavity, okay? It's fluid buildup. It's possibly due from the heart, like poor pumping of the heart, or also inflammation. In this cat's case, there was actually a tumor in the mediastinum. Okay, so essentially the lungs are like floating in the chest cavity because they're surrounded by water molecule, or just water. I guess it's molecules, but anyways. Yeah, so that's that example that we used in class. Okay, let's move on to some of those systems that we had. So we know that our respiratory system has two main functions, okay? The primary is going to bring oxygen into the body and CO2 out of it. The respiratory system works together with your heart. That's why we cover it. Secondary functions are voice production. We'll figure out that our larynx is our voice box, regulation of body temperature, and then also regulation of acid-base balance, and then sense of smell. So there's two versions of respiration. We have external respiration, which means oxygen and CO2 exchange between inhaled air in our alveoli, in our lungs, and the blood flowing through the pulmonary capillaries. So let me give you an example of external respiration. In with the oxygen, out with the CO2. I did it. Okay, further breakdown, gas exchange in the lungs. We have oxygen coming in our alveoli. This picture is an example of an alveoli molecule. We also talked about it in class. The blood from the pulmonary capillaries come from the right side of the heart, and then they're going to be in the body. And remember, because they're coming from the right side of the heart that's already traveled through the whole body, it's not going to have any oxygen, or it may just have like a little itty bitty bit, okay? And it picks up the CO2, which is that waste product, okay? Through respiration, we give CO2 to our alveoli to make that gas exchange, and it gets rid of that. So then we have internal respiration, which is the exchange of O2 and CO2 between the blood in the systemic capillaries. So, like I said, we breathe in, we breathe out. Then on a cellular level, those itty bitty 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 cells, those are going to breathe as well, okay? And again, that's that foundation of that in with the oxygen, out with the CO2. Let's talk about these structures. We've got the upper respiratory system, okay? This is going to be everything cranial to your lungs. You've got your nostrils, also known as your nares when we're talking about veterinary regards. We have the nasal passages. We then have your pharynx, and then your larynx. And then we move to your trachea. All right, our nares are also known as our nostrils. They're external openings of the respiratory tubes, okay? They lead into our nasal passages. Then the nasal passages, big thing here, we've got a left one and we've got a right one. Between the nostrils and the pharynx, and then we then have the turbinates, which you can see up here. This is going to be where your turbinates kind of go through. They're found in the nasal passages. There are multiple passageways within the structure, and this is also where our sinuses are going to be found. We then have a nasal septum that separates the left and the right nasal passages. We then have our hard and soft palates. They separate the nasal passages from the mouth. Our hard palate has our palatine and our maxillary bone. Remember those from when we talked about the bones. Yeah, they're important. And then we have our soft palate, which is like cartilages. Again, those turbinates, they divide each nasal passage into 3 main passageways. And then little med term here, passageways is also classified and labeled as a meatus. Okay. Their job, big thing here, make sure you know this, they divide nasal passageways, they allow air to wrap around the scrolls so that the air is warm when you breathe, and then they also trap things in the mucus and the nasal epithelium to avoid any particles, okay? So, like, we have to have boogers, okay? Thanks to our turbinates. Okay, the nasal meatuses, or the passageways. There's 4 on each side. Dorsal, middle, ventral, common, okay? So, we have dorsal, dorsal, middle, common, and ventral. Okay, common's in here, middle's out here. Okay, you probably could get a better drawing yourself, but that was my attempt with the mouse. All right, here's an example of turbinates. Here's our dorsal meatus and our ventral meatus. Upper respiratory structures, we have, make sure you know these, just kind of going through that list. We have the back of the nasal cavity, also known as back of the throat, which is our nasopharynx. Where the pharynx meets the larynx is the laryngopharynx. The opening of the trachea is known as the larynx. Where the oral cavity meets the pharynx, aka back of the throat, it is the oropharynx. The covering of your larynx is your epiglottis, which is a leaf-like structure. It's made of cartilage, and it closes over the larynx, okay? We'll talk more about this here in just a minute. But big thing here, when you breathe in, it opens. When you eat or swallow, it's going to close. So it covers the larynx and the trachea when you eat or drink, okay? Opens up when you breathe. These nasal passages, big thing that I talked about here is knowing that the pseudostratified columnar epithelial cells is what's going to be through those there. And mucus is secreted by the mucus glands and those goblet cells. And the cilia is going to protect the cell surface from that mucus layer, with that mucus layer. Okay, remember, nasal passages, they're warm, they're humid, they filter some air. The air is warmed by blood flowing through the blood vessels just beneath the nasal epithelium, okay? It would be really painful and not good for our system to get cold air going through there, okay? We want a nice, warm, kind of humid space. The air is filtered as it passes through the winding passages produced in the terminate. And this is making sure that also that particles don't go through there. Okay, big thing here, make sure that you know, based off of this picture, that we have paranasal sinuses. They're ciliated out pouches of the nasal passages that contain in that space, and they're in our certain skull bones, okay? We've got 2 frontals and 2 maxillary. All right, recall on our pharynx, back of the throat. Common passageway for respiratory and digestive. Digestive because it has to pass through there, okay? It has a soft palate, which divides all those things. Remember, it's cartilaginous, so it's got a lot of cartilages back there. The reflexes control actions of the muscles around the pharynx, okay? And that reflex is like, is this water? Is this air? Is this food? The larynx and the pharynx work together to prevent swallowing from interfering with breathing and vice versa. And we've already talked about that. So after swallowing, the epiglottis will open up and the larynx is reopened and then resumes normal activity. And then your larynx, okay, is that short irregular tube containing your pharynx with the trachea. It's composed of segments of cartilage that are connected to each other and the surrounding tissue muscles. It's supported in place by the hyoid bone, okay? Remember that weird structure? Yep, that's pretty important. And then our cartilage components consist of epiglottis, arytenoid cartilages, thyroid cartilage, and cricoid cartilage. All right, so we talked about laryngeal cartilages. Let's break this down. The epiglottis, it's single, it's leaf shape, it projects forward from the ventral portion of that larynx. Now, during swallowing, the epiglottis is pulled back to cover the opening of the larynx. In mammals, we call the larynx like the voice box. It's going to flutter, which is actually kind of one reason why we see people with snoring. And then also like people, there's also like, those brachycephalic breeds, those smush faces out there. Yeah, I dog sit for a Frenchie and I just don't sleep because they're like all the time. And then the glottis is technically the opening airway. Okay. Now we have the arytenoid cartilages. They're paired. They're attached to the side of the vocal cords. They're muscles that are adjacent or that adjust the tension of the vocal cords by moving that cartilage. That's where we get our different sounds. The voice production is the vocal cords. There's two connective tissue bands that attach to the arytenoid cartilages. They stretch across the opening of that larynx and parallel to it. So the more tension, the higher the pitch. The less tension, the lower the pitch. So functions for the laryngeal cartilages. Sound, prevent foreign body inhalation. That helps. And we're going to have control over our opening and our voice box and all that. This was just an example of some additional videos if you wanted to see for intubation. Moving on to the trachea. It's short, it's a wide tube, and extends from the larynx into the thorax. It's divided into two main bronchi that enter into the lungs. Okay, I know I talked about this in class, but it's really important that we make sure that we note the bifurcation. I definitely want you to understand and know that, okay? And we're going to go through it a little bit more when we get to the AnP lab. It's composed of fibrous tissue, it's got some smooth muscle, and it's held open by the hyaline cartilage rings. It's lined with ciliated epithelium as well. So ask yourself, what is the primary function of the respiratory system? In with the O2, out with the CO2. What are the secondary functions? Well, voice, temp, pH, smell. What is the term for the back of the throat? Hopefully you were saying nasopharynx. And then which structure is known as the voice box? Hopefully you said a larynx. Okay, so this was another case study that I talk about. I'll just go through it very quickly. In class, you can follow this link, although you'd need a dove count, which I don't think you guys have yet. So if you want to look up supplementally, well, one, you could ask me, I could show you in class again, or if you wanted to look up supplementally canine surgical intubation, something like that. But this is, I talked about a patient where I measured for my endotracheal tube to go down into and probably stop about here, okay? But instead, with movement and putting into surgery, it went into a bifurcation here, okay? And then I talked about how, what anatomically happens with that, and then also how this affects my patient, and then also saying hey, sometimes you do everything right, and then something just happens, okay? All right, we can cover more of this in class when we grab an ET tube and do our lung dissection. All right, so here's where we talked about a collapsing trachea, okay? Here's a common signalement for a patient with collapsing trachea, and then here is a common X-ray example, okay? Here's our diaphragm, here's our heart, here's our thoracic vertebrae, cervical vertebrae, scapula, humerus, olecranon process or elbow, and then we have this lovely structure, boop, that is our trachea. Notice here that there is a blockage or a stopping in at the trachea, okay? That we would call trachea collapse or collapsing trachea, okay? That's bad. There's no airflow going through there. And then this was an example that I talked about where there was actually a foreign body, just found it on the internet. All right, moving through our structures, we have our lower respiratory tract, okay? That's going to consist of our bronchi, our bronchioles, our alveolar ducts, and the alveoli. Okay, we have the bronchial tree, and each bronchus divides into smaller bronchi, which then divides into even smaller bronchi, and then to tiny bronchioles. We can see from this picture here, let me get it better. Trachea, bifurcation, bronchi, bronchioles, beep, 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 beep. All this, if you took this picture and turned it upside down, it would look like a tree, right? So your lungs are like a tree. The alveolar ducts end in the groups of the alveoli, and they're arranged like a bunch of grapes, as we can kind of see down here, okay? And then each little grape is like a sac, okay? Now, it's really important for us to remember that the autonomic nervous system controls the smooth muscle fibers in the wall of the bronchial tree, okay? So and remember, our breathing is going to be involuntary, okay? We don't have to be like, breathe. Now, sometimes when we're stressed and anxious, we may be like, okay, 1, 2, 3, 1, out, 1, 2, 3. But ultimately, your system's going to do it itself, right? Definitely make sure that you know the difference between bronchodilation, which is the bronchial smooth muscle is going to relax, okay? And this aids respiratory effort during intense physical activity, okay, if we're like running a marathon. And then know the difference also with bronchoconstriction. So we have bronchial smooth muscle, it partially contracts. This is going to reduce the size of the airway, and irritants inhaled air can cause bronchoconstriction. So make sure you know the difference between those. Now let's get down to the alveoli. It's the site for external respiration, okay? Remember external, lung space, out, internal cellular level, okay? It has simple squamous epithelium and surrounded by the network of capillaries. One example that I used, I don't know if it was good, but if you think about your fist is an alveolar sac, and then you put your hand over it, and all your phalanges are kind of like the capillaries that are going to absorb that, okay? And the reason this can recur is because of diffusion. Remember, diffusion is substances where an area of high concentration move to an area of lower concentration, okay? And then, so the body can diffuse oxygen and CO2 from an area of high concentration to low concentration, like we talked about. So, because the alveoli are simple squamous epithelial cells, there's that one like flat cell area, that one barrier that's covering them. And that's between that and the capillaries. That's why they can diffuse past it. Think of it as like entering a room and your destination. You would only, like, when it's one cellular level, it's going through one door instead of 12 different doors or 12 different cells. Also with diffusion, think of a crowd of people, okay? I used a grocery store example. So a line of people where they're in line 7 and there's a bunch of people there, we're naturally going to try to gravitate to, lane 2 where there's only one person or there's nobody over there. Oh, I also talked about surfactant. Remember that surfactant is that fluid substance that's inside of the alveoli that makes sure that it doesn't collapse all the way, okay? And then that, sorry, I clicked through, was a picture of a glass ball surrounded by macrame as like an example of the glass ball is like an alveoli filled with air, and then the macrame is like the capillaries surrounding it. Let's talk about the lungs. Each lung has a base and an apex and a convex lateral surface. So the base is in the caudal part of the thoracic cavity. It lies directly on the cranial surface of our diaphragm. So our diaphragm is that big muscle that's going to help with respiration. It also divides our thoracic and abdominal cavity. So the apex is going to actually lie to the cranial portion of the thoracic cavity. The convex lateral surface lies against the inner surface of the thoracic wall. And remember, our mediastinum is the area between the right and left lungs. Big thing here is knowing that we've got different lung lobes, and different lung lobes can also be seen in different species. So, and then the sizes in the lobes are going to vary. Here's an example of our lung lobes, and when we get to dissection on Thursday, we're going to look at all these lung lobes and label those as well, okay? In this radiograph, we can see the right cranial, left cranial, right middle, right caudal. Accessory is going to be down here, left caudal and left cranial caudal, but we could also call that middle. All right, this area here is going to be the hilus. This is where air, blood, lymph, and nerves enter and leave the lungs. Okay, we'll hopefully find that during our dissection as well. Now, pulmonary circulation is when we get blood without any oxygen. It's going to enter the lungs from the right ventricle, okay, and the heart through the pulmonary artery. The pulmonary artery splits into the left and right pulmonary arteries, and then that is going to enter the two lungs. I guess we could say like arteries away, that pulmonary trunk, and then we get into those like individual ones, the left or the right one, okay? And then the arterioles enter the capillary network around the alveoli. And that's when that alveoli is like, here, red blood cells, have some oxygen, okay? And then that oxygenated blood is going to return to the left side of the heart through the pulmonary veins in that left aorta, okay? Here's an example. We'll also talk about it more in class. Now, our thoracic cavity, make sure to remember that it's bound by the thoracic vertebrae dorsally. And then I talked about those intercostal muscles. We really want to make sure that we know and understand that between there is that muscular layer, and that's called the intercostal muscles. Okay, they're laterally and they're also to the sternum ventrally. The mediastinum, again, that's the area between the lungs. That's where our thoracic cavity has our heart, our trachea, our esophagus, blood vessels, nerves, and lymphatic structures. We also talked about the pleura, which is going to be that thin membrane that lines the thoracic cavity, and it's going to cover the organs and the structures in the thorax. Now, there are two different layers. There's an inner visceral layer, which covers our thoracic organs and our structures, and then there's a parietal layer that lines that cavity, okay? This is like a looking, if we sliced a model in half of an animal, we would then look kind of down in it rather than looking on the side of them. Okay, so we've got our sternum, our thymus, our mediastinum, and there's that visceral pleura and that parietal pleura. Okay, our diaphragm, looking at this x-ray, here's where our diaphragm would lay. That's going to be thin, dome-shaped skeletal muscle sheet. It forms caudally bound of the thorax. It's important for respiratory muscles. It's going to flatten when it contracts and it enlarges when we take inspiration. Now, we talked about gas exchange together, and then we did a breakout and moved on with that. I'll lightly cover it in this, but we'll talk about it more on Thursday too. So inspiration Yay. Is the process of drawing air into the lungs, or inhaling. It results from enlargement of the volume of the thoracic cavity by the inspiratory muscles. It's the main inspiratory muscle is going to be your diaphragm and your external intercostal muscles. That is like such a test question. Definitely going to ask you that. The external intercostal muscles are located at the external portion of that rib space. And then expiration, the process of pushing air out, or the exhaling. Okay, it's going to decrease the size of the thoracic cavity. Inhale, increase the chest cavity. Exhale, it's going to decrease the space and the size of the thoracic cavity. Okay, this is thanks to the internal intercostal muscles and the abdominal muscles. Okay. All right. Process of respiration. So this is where I talked about how our bodies can pick up on certain pressures. Okay, so like when I talked about a scuba diver, when they go down far, far, far underwater, okay, there's a lot of pressure. You have to like equalize and pinch your nose and blow out just a little bit to get your ears to pop, or like diving down in a pool and going to the deep end, okay, there's pressure. There's also atmospheric pressure that's floating around us and everything. Well, your body has pressure too. It's important for us to note that the pressure within the thorax is negative with respect to the atmospheric pressure, okay? So it pulls lungs tight out against the thoracic wall. And lungs follow passively as movement of the thoracic wall and diaphragm alternately enlarge and reduce the volume of the thorax. So negative intrathoracic pressure helps draw blood through the veins and into the atria. This is where we could also think about positive pressure ventilation, and sometimes we may have to breathe for our patient because there may be different pressures that are building up. I also talked about how if we hold our breath, our CO2 starts to rise, and that can increase our lung space as well. All right, this is where I talked about you need to know these definitions. Tidal volume, volume of how much air is taken in and out during a breath. Okay. Talked about here that we noted during anesthesia, we're monitoring their breath, and that's going to vary on the needs. So if you're running a marathon, you're going to be increasing that tidal volume because you're going to be like more air in, more air out. If you're sitting in class or watching TV, then your tidal volume is going to be lower. The minute volume is just that tidal volume, but more so in how many is happening in a minute. Your residual volume is going to be the volume of air remaining in the lungs after that maximum expiration. Remember that surfactant is going to prevent that alveoli from completely collapsing, okay? So it's always going to be air remaining there, and it's spongy. And then dead space is air in the pathway of the respiratory system that's not doing anything for gas exchange. The example I use with this is if we passed an endotracheal tube and it was too long and there was such excess from the patient's like nares to the oxygen hookup, that would be dead space, and we would want to cut that too. But you'll learn more about that in CP. We just need to establish those definitions now. So this simple definition for our alveolar gas exchange can be noted as simple diffusion of gas molecules according to the concentration gradient. So oxygen diffuses from the alveolar air into the blood of the alveolar capillary. And then CO2 diffuses from the blood into the alveolus. Okay, so I just thought this was cute. This is where we did our breakout, and then we went over kind of this process together. Okay, so your alveoli are here. They've got oxygen. This is blood is coming in through here. It is giving away its CO2 to then get breathed out or exhaled, and then it's taking in red blood cells and then back, and then there we go, to the left side, and then it goes through our body and starts that process over again. To follow up with our pressures, partial pressures of oxygen and CO2 in the blood of the alveolar capillaries is determined by the partial pressure of oxygen and capillaries in the alveolar air. So biggest thing I talked about with this is noting that, hey, we talked about atmospheric pressure. We talked about that there's pressure within our lung space that's negative pressure, and so it keeps everything tight in there and stuff. And the tighter we keep that negative pressure, the more things are going to be systemically blood flowing. When we introduce certain gases, there's also pressures that are in there, and this can affect our respiratory rate, our blood pressures, and everything like that. So there's a direct correlation with the amount of partial pressure that's in like an inhalant that we would use for anesthesia and the pressure that's being put within our thoracic cavities to pump our blood through our vessels and all that. Okay. I said kind of not to focus too hard on this, but at least have an understanding of under pressure and that it's important. Okay, the respiratory center. So, what tells your lungs to breathe? Your medulla oblongata within your brainstem. It controls the respiratory muscle contractions that are taking place. It's got a timing and a strength, and it hits go when it's needed. But you don't have to tell it. It just automatically does that. Thanks, brain. This is where we're going to take a breath in, take a breath out, and then also if we needed to hold our breath. It can be consciously controlled for brief periods. And we definitely want to make sure that, like, if we hold our breath, then it almost, like we talked about, it almost is like a glitch in the circuit in the system. If you voluntarily hold your breath, your medulla oblongata is like, I'm getting a signal and you're not doing it. Hello. Okay. And then eventually you would hope that you would breathe. Now, there's a mechanical control system for our lung space. Okay, we need to go through the mechanical as well as the chemical. So we have stretch receptors in the lungs, and they set the limits on routine resting between our breaths. The respiratory center is going to send out those nerve impulses when the lungs inflate to a certain point. That's where our lungs just don't keep growing and growing and growing. Okay, it's the stretch receptors that are like, okay, you've gone too far. Like, this is as far as we go, like a balloon. Okay. It stops muscle contractions that produce inspiration and starts contractions that would then start our exhale. Okay. This is basically saying that we have another set of nerve impulses that are going to be sent when the lungs deflate significantly. So it's going to stop the expiration and starts the process of inspiration. Okay. There's where I talked about the holding your breath. So your stretch receptors are part of your mechanical control system. Okay. That's why we don't overexpand or underexpand. And then remember that surfactant's also in there when we exhale to make sure that our alveoli don't go too flat. Now, that chemical control system. This adjusts to the normal rhythmic breathing pattern produced by the mechanical control, which are like those stretch receptors. So our chemical receptors in the carotid artery and the aorta, they're going to monitor our CO2, pH, and our oxygen intake. So our blood level of CO2 and blood pH they're going to be linked. When we have an increase in CO2, which again, breathe in oxygen, our waste product is CO2 from our respiratory system, and as our blood picks up everything, then gets filtered through, and then we breathe that out. Okay, if we have an increase in CO2 in the blood, we're going to have, and we've got a decrease in blood pH, it triggers the respiratory center to increase the rate and depth of reception. So if my body is filled with a bunch of CO2 in my bloodstream, okay, then my body's going to be like start to pant, so increase my respiratory rate so that I can get more CO2 out of my bloodstream. Now, when we have a decrease in CO2 in blood, we then see increases in blood pH. So it's increased blood pH level, that's going to make the respiratory center to decrease the rate of depth of our respiration. So if I'm panting, hyperventilating, it's like, hey, slow down. You're breathing too fast. We don't have enough oxygen to balance that out. Another medical term here to make sure you know is hypoxia. It's that decrease in blood oxygen level. Ooh, excuse me. Slight hypoxia will trigger the respiratory center to increase the rate and the respiratory rate. In severe hypoxia, the neurons of the respiratory center can become so depressed that they actually, that adequate nerve impulses can't go to the respiratory muscles. So severe hypoxia, everything kind of, those neurons shut down. They're not getting oxygenated and they can't say, hey, it's time to breathe. This is where we experience our patient being too deep under anesthesia. Okay, this is Pearl. She's a 1-year-old female lab. She presented for ovarian hysterectomy. You are the anesthesiologist for Pearl, and you decide that she needs to be ventilated, so maybe she stops breathing on her own. You give her several large breaths in a row, and then stop allowing her to breathe on her own. But she doesn't start taking a breath. What is happening? Well, the signals in the lung are not saying, hey, medulla oblongata, we need to fire that thing up and breathe again. Why? Because you were doing it for her, okay? And maybe we were overdoing it. So those nerve impulses are like, hey, we don't need that. And then also, maybe we've got enough oxygen floating around in our system to where those receptors are not telling the medulla oblongata, hey, we need to breathe again. The hopes here is that if we overventilate, that if we pause, give it time, that her respiratory system will kick back in. If not, that's another lecture. That's another time. Yeah.